Welcome everyone for another VITA Learning webinar. Today we have the exciting Mr. Mark Wagenseal, Dentures Extraordinary Scrumptious,
Nice.
the technician to watch,
Nice.
the denturist that's going to help us learn more and understand better and move forward with any case that we have that comes into our laboratory or in the office. Mark Wagenseal is a denturist, so he's a kind of a wet finger technician is what we kind of say here in the United States. But so he'll be speaking towards, to lab technicians, to denturists, and clinicians. So he's got a wealth of knowledge, a lot of information. Today's program is going to be upper dentures, addressing the issues of unbalanced lower natural dentition, which is a can of worms on itself. Just a couple notes before we get going. Everyone's phone is on mute, so if you want to send in a question, you're going to use that panel that's located on the right-hand side of your desktop. That panel, there's a question set. Go ahead and type in your question, send that through. And then at the end of the program, we're going to have a Q&A session, okay? The workshop's going to be recorded. We have a lot of recordings of Mark from last year, and then we're continuing this year with some webinars, these live webinars. These are all recorded. You can find them on the VITA YouTube channel. Just type in VITA North America YouTube, and that will come to the page, and you'll be able to view today's webinar as well as others that Mark has graciously provided us. So it is recorded. Anybody who has a CE question at the end of the program, you'll be notified. You'll be sent a notification from the marketing education team using that registration information that you provided us. So Mark Wagenseal, a denturist, certified denturist. He's a VITA Global Certified Trainer and Management Consultant for VITA North America and for VITA Worldwide. He's a licensed denturist, a dental technician with over 30 years of experience. He owns and operates Heritage Denture Center in Edmonton, Canada. This is his own clinical denturist practice. Mark has spent his career focusing on how dentures integrate into the mouth and body. He inspires a unique awareness of occlusion and professional growth of technicians, dentists, and other denturists. So welcome, Mark. I hope everything is well with you.
Yes, good morning. Hi. Super duper. Happy to be here.
All right. It's glad to have you here.
Awesome.
So how are things in Canada?
Well, we're still here.
Excellent.
It's okay. Yes, life is okay.
Well, that's all we hope for, right? Moving on. So moving forward in today's weird world. So I'd like to introduce now Mr. Mark Wagenseal. I'll let you take control, and you are now going to be the presenter, Mark.
Okie dokie.
And you are there. It is your show, and as soon as I see your computer screen and your start, I will let you get off to the races.
It said show my screen. I hit yes. How's that working?
It says now viewing Mark Wagenseal's screen, but I still see the connected to go to webinar page. Let's get started. So
how about that?
Now we got it.
Our common single
denture issues. Yep,
awesome.
I see that.
Okay, right. Okay. Hey, good morning, everybody. Hello, my dear colleagues, and welcome. Thank you for investing in yourself. This is about you. This is about you being a superhero, whether you see a patient directly or not. There is a patient at the end of the chain here that is wearing a denture. And in this case, a single upper denture usually to lower natural occlusion, which is anything but perfect. And yet we're here to try and tasked with trying to make a denture and make it work. Gosh darn, that's difficult to do. So thank you for taking time out of your days, and hello to all my dear colleagues that have sent me some messages on the side saying hello, and they were looking forward to joining us today. So hi, everybody. And to those of you that are new, thank you again for coming and investing in yourself. This is a quasi little repeat from last year. We had a lot of interest in it, and not everybody can always join with us every time. So we thought to again run a program about single dentures again, to act as a repeat, a review, but also then for people to join in that are new to this topic. So thanks. So good morning and welcome. Number one, we do not slap teeth together. Woot woot. I really now see that at year 35 of my career. I'm 52 currently, and I started caring for patients when I was 17. So it's been 35 odd years of my life now building dentures for patients. And I want to impart with you my journey and what I've sort of figured out along the way, and as I say, my head banging against the wall when things should have worked, but they didn't. And so this is my journey and my sort of opinions and experience of how I tackle things. So thank you for joining me. I ask for your patience and understanding. I'm going to probably disagree with a lot of things that are held to us and our standards that we follow. And I'm going to shake that up a little bit. And I'm going to disagree with a lot of things that we were taught initially. But I'm going to back it up as to why and my journey of getting out of my own way. That's what my wife calls it. Mark, you got to get out of your way. And that is a reminder every day that it's not about me, it's about a patient. And I'm here to gain information from them and then facilitate the denture for them using my experiences, yes, and wisdom, but this is built around the person, not around me. So Dr. Carlson said it right. This is about fitting dentures to the patient, not the patient to the dentures. And so this is another eye-opener for me. Our common single denture issues that we experience are denture teeth chip, break, and pop off. Patient can't chew well with the new denture and they complain that it's loose, and especially that the new denture is more loose than the old one. That's common with an upper denture. Multiple relines with no fit success, and we check the extensions and the border molding and we feel that it's correct, but the patient still says that the plate is loose. Denture base cracks and fractures, that's pretty common on an upper denture. Food collects under the denture, but again, we've relined it and it's not warranted. The reline isn't warranted anymore, yet it still happens, and the new teeth feel too big. Soreness, and these are some of the general complaints that we field and see clinically. And these issues cause us stress. And my goodness, we've certainly had enough of that in our lives. I can just again chatting with our patient base here, people are just tired. And they, I guess, for lack of a better word, want their lives back, I suppose, or as we settle into our new normal here. And so I'm feeling that their tolerance level is also been reduced, and any of the other direct care practitioners or wet finger practitioners that are listening in, curious to see what you think as well, but I think that people are just a little bit more edgy than what they used to be. And so this is about getting control of ourselves and our practice, and even in the laboratory, getting a hold of things to help manage that stress, because it's palatable. And the stress over time leads to burnout. And this is a problem in our professions, that we see a high burnout rate. Professional happiness. In 2019, the World Health Organization has now officially listed burnout as a classification of disease. And what that means is burnout is categorized as feelings of depleted energy or exhaustion, increased mental distance from one's job, negativism, or cynicism. And the biggest one is, I want you to clue into the cynicism. We hear comments about our patients or the doctors and such, and we make those comments and we get cynical. We get cynical on them, that they're ourselves or our staff members, and we start making cynical comments, and we kind of blow it off, but they're there, and we have that degree of cynicism in our job, and then that relates to reduced professional efficiency and a disrupted sleep pattern. We don't talk about this in our professions and a lot openly, and I am, and I'm going to, and that's part of my mission now is to address this with everyone, and thank you. We have to get a hold of this. Our mental health is important, and it's okay to take self-time and self-care, but it's also to try and control things that you can. So let's talk about the denture aspect and things that we can control here in our offices, whether it's a lab or a clinic, etc. So one of the major signs of burnout is if you go on a holiday, even a long weekend, and you come back and after a couple of days of work, it feels like you've never had that holiday, then my dear colleagues, you're suffering from burnout. And let's call it like it is, okay? And we need to get a hold of that. So let's start our journey. So again, what is freedom and centric? This plays into how I'm going to set teeth on lower natural dentition. So freedom and centric, by definition, is the flat area in the central fossa, which an opposing cusp comes into contact, yet permits a degree of freedom in eccentric movements, uninfluenced by a tooth incline. So that means you can touch your teeth together in centric, and before you go into eccentric movements, you can wiggle a little bit. And so that's the big issue here. Jim, can you just see me? Am I still there? I've switched screens, so can you just pop on quick?
Yeah, I
Can you
see your
me?
real life example. I can see you.
You can see me?
Yes.
Or should I switch to the other camera?
Well, it's up to you. Whatever you may be doing. I see your PowerPoint and with your a picture of you or your live stream of yourself.
Hang on as I just make everyone dizzy with everything. I'm going to switch cameras just to make sure. All right. Okay.
All right.
Now I'm upside down. Let's fix that. Whoa, there we go. All right.
All right. You're cool. Good.
Aye. Okay, thank you. All right. Let's turn the light off. So there we go. Okay, freedom and centric. So we can touch our teeth together in centric. So I want everyone to try this. So you touch in centric, and now you wiggle. Can you see that? My lower jaw can move a little bit within centric before I go eccentric. So I'll do it for myself again. Now I'll go eccentric, and I'll stay in centric. There's about a millimeter little shift in our bite. So what that means is we are not locked in centric. We come together and there's a little bit of wiggle room. I call it a helicopter pad that we land in. We're not trying to land in a bullseye. So that was one thing that I wanted to address. So I'm going to switch cameras back. So one moment. Thank you. Okay. So that was our real life example. So why is this important? Why can you touch together in freedom and hold together? And why is freedom important? And why is freedom good? Well, freedom is good, and freedom in occlusion is good. And so everyone say it with me. Ready? Freedom in occlusion is good. Woohoo! Why is this important? We've been locking the bite in unintentionally because that's what we do. Our equipment does it. The teeth that we use do it, and we were taught to do it. So we need a little bit of that helicopter pad to land in, like the image on the left of the screen. If you don't, and when the patient comes in and tries to close into occlusion, they're going to hit and slide into position. The hit and slide is the cause of all of our problems. The hit and slide is the problem. So where are we getting at is we are asking a patient to bullseye land centric each and every time. That is impossible, especially when you consider that this is a senior citizen, usually wearing the denture, and that you're asking someone now to bullseye land in centric every time accurately is not possible because your jaw and the movements of the muscles aren't 100% accurate. And that's why nature gave us freedom and centric. Yet there's only a handful of denture teeth on the market for complete upper and lower dentures that have freedom and centric principles on them. That's it, a handful. There's like 3 of them. And all the other teeth that we use, yeah, they work in balance, but they have no freedom in centric. They're tight in centric. And what happens is then that causes the rock on the denture or on the upper denture. So it's not possible for a patient to do this every time, and there's no nerve into the denture or the denture teeth. And this is important. We forgot there is a nerve into a natural tooth, and that's a pressure sensitive nerve. It can feel pressure on the tooth. It tells our brain in real time, stop biting because you're overloading the tooth. And now we lose that nerve when that tooth is extracted. So that's called proprioception. We have that ability to perceive and feel pressure. It's brilliant. When we have our natural teeth extracted, that nerve is then severed and cut. And so now our brain has to figure out, well, wait a minute, number one, where did the tooth go? Number two, now it says, well, wait a minute, what's this denture? So now we have a denture pushing on the gum surface. So how does our central nervous system feel the denture? And how does a patient tell that they're in centric or that they're chewing? Well, now they're using the hydraulic load on the ridge and on the tissue to determine that. So it's a learned pattern. So the patient has to learn it. So when they swallow in centric and they touch and they swallow, it's a light coming together of the teeth. It's a light touch. So the central nervous system will understand, geez, when I swallow, it puts this much pressure onto the ridge surface. And then when I eat, it's putting down more. I can feel more pressure down onto the ridge surface. So that's how the brain or the central nervous system starts to differentiate and distinguish the difference between, say, just touching together or chewing. So when we ask a denture patient to close, they're trying to feel the pressure of what they believe is just, oh, close is just what it feels like when I'm touching and not chewing. And so that's subjective. And so that's why I don't like using the word bite or close to a patient anymore. We have to understand the central nervous system and how it's understanding. The central nervous system has to function with something it can and cannot feel. It can feel the real natural teeth, but it can't feel the denture directly because there's no nerve into it. So when you don't find your centric accurately, you hit and slide into position. It's a locked in bite, and then it as the red arrow indicates, it's going to wiggle and wackle the denture, and that's what's starting to wiggle and wackle an upper denture. When the patient says it's loose, that's because there is a contact. It's hitting and sliding into position because we inadvertently locked the bite in. So we have to follow the process and the understanding of not locking the bite in. That's going to eliminate the rock on the denture, and we have to give them a little helicopter pad to land in. So on an upper and lower denture, this is what it looks like. So you can wiggle it, and that's what I was doing for you live, and that's what you were doing for me in the example. This is the eccentric movements, or our classic working and balancing movements. And then again, that little wiggle in the middle is that freedom and centric. So that's what it looks like, sort of from a position for you to put a mental picture onto it of what it is and what it does. Now that's going to be incorporated within a chew cycle of a person. So this is something that they never showed me way back when in school, that I'm going to show you now, is that we have a chew pattern. So these are examples of patients with real teeth eating. So the first example is an apple. So watch. Is it straight up and down? No, the patient is coming in at an angle, and it's almost like a teardrop that the lower mandible opens, cycles, and closes. And when it closes, it's coming in at an angle, and that's where the hit and slide happens. Remember, our natural teeth have proprioception, they have the pressure sensitive nerve, and they're able to tell if they're hitting. So they're not hitting because they're coming in and they're touching into centric, and they have that little helicopter pad to land in. So now there is a definite chew cycle to the patient, an angulation of how the mandible works for the patient. This is a beautiful example. You can see it's fluid like a teardrop. They're coming in and they're touching. And there's a helicopter pad to land in centric. So we have to be careful that we don't lock the bite in on a single upper denture against lower natural dentition. And we typically have done that. And I've been guilty of that as well in the past. This is really good. Watch this. So now look at the chew cycle of this patient. You see how it's more vertical? Look, see how it's a little bit more up and down compared to the other ones that we've seen. So that tells us that everyone has some type of a chew cycle. It's unique to them. It's like your retina scan or your fingerprint. It can either be flat, oval, ovoid, or teardrop. Depends on the person, depends on the situation. So what we have to watch for is, again, the black circles denote where we'll find that hidden slide. And then that causes the denture to rock or causes the problems or causes, and is the root cause of all of our denture problems that we discussed at the beginning of the presentation. And this functions within the chew cycle, which is the green arrows. So then the red marks are where it'll hit and slide, and the difficulty and the difficulty for us to clinically see that, because again, there's no nerve. The patient can't tell. So this is an example now of a patient of mine. Now I want you to watch her mandible as she's saying a common word that we use clinically during a wax try-in. You can see the mandible move. See how it thrust forward? So now there's a chew cycle associated with this patient. And some of the words that we use clinically when we do a wax try-in are 66, Mississippi, count from 1 to 10, say the days of the week. And what we're trying to watch for is we're looking for the midline, the smile line, and all the aesthetical values of the teeth that we're looking for. And over the years, I've retrained my eye to watch the functional pattern of the lower mandible. So we can actually use some of these keywords and actually look at the mandible and see how the mandible is moving. And that's going to help us with our chew cycle. Because that's one of the questions I always ask myself was, well, Mark, how can you identify a chew cycle without watching someone chew? So I don't have a deli in my office where I can sit down and watch every patient eat. So I've retrained my eye to look at the patterns, and then that tells me how I can set teeth. So this is something that you can take for your own knowledge, discuss when appropriate. So you either, as a direct care denture practitioner, start to address this yourself and watch for these things, or as a technician, you can bring it to the attention of the doctor to say, hey, can you just shoot me a video of this quickly, please? Because it is getting a little easier now to send videos with all of the apps and platforms, etc., that you can look at this. Because now this tells you how you can set teeth, because as she pushes and her mandible goes more towards her left and forward into her left, I can clear out that area more because I know that's where she postures. And then I can make those corrections in the lab. Then, because again, she can't feel the teeth hit. She only feels the result, which is, oh, Mark, my dentures are loose, or oh, Mark, food's getting underneath, or oh, Mark, the denture comes loose after I talk for a while. That's because the teeth are hitting, but they're not hitting so much that it's clinking out of her head, but it's enough that it's hitting and it's disturbing the fit. So she can feel the result. She just can't tell me, oh, it's hitting, because again, no nerve. I can feel the raspberry seed. I can feel if my bite's wrong because of the nervous system. So here's another patient. Watch. See her jaw move? Look at that thing. Look at that thing move, man. Unbelievable. So now I'm getting her to say the days of the week. Okay, so phonetically speaking, the days of the week and the months of the year in English and every language on this planet will denote and the phonetics and the base language building blocks of that language. So it covers the phonetics of that language. So I'm going to have the patient say days of the week, months of the year in English and a mother language if they have it. And then I'm watching the mandible move. And then that tells me how I can manipulate teeth while I do the setup to allow so that they don't rattle around and knock. So on her, if you look, I did, what is that, like a 5mm overbite, things I never thought I could get away with and do. I've now built this thing with an overbite on it. And if you look at it, it's substantial. So but I gave her the clearance on especially her left side as she functions and postures that way. So by studying her chew cycle, and I can see what happens in real time, I'm able to build things I never thought I could build or never thought technically would succeed. But this is about now building the teeth for the patient, not the other way around, and getting out of my own way and challenging what you believe and what you thought. So this is another example. I colored the lower anterior teeth for this young lady. And now she's going to say 66. But you can see her jaw's moving forward. It's coming forward fairly straight. There's the odd little posture there. But of course, if you look at her upper natural dentition, you can see there's some character to it. And then her overbite as well is about 4 or 5 millimeters. But she's not chipping out her teeth. Here is a complete upper denture and six lower anterior teeth and the first bicuspids and premolars and a lower cast frame partial denture. Watch this patient eat. Look at that chew cycle. Is it straight up and down? No. Look at that thing. So there it is with a partial on the bottom and a complete upper on the top. You have to allow for freedom in centric. We do not slap teeth together, my dear colleagues. We don't do that. This is very difficult work because we're trying to build a denture that functions inside someone's mouth that they can't feel directly and the central nervous system can't pinpoint directly. So these chew cycles exist, and those chew cycles are influenced and its interaction, it influences. We need the freedom in centric, and then we need to modify the teeth within that chew cycle. So this is what it looks like now when we sit in the lab, and we do standard working and balancing. So we have working and balancing occlusion. This is what we typically do with an articulator. We go left and right because that's what someone taught us, and that's what we're supposed to check. And we're supposed to check to make sure that we have working and balancing occlusion, whether this is on a complete denture or whether this is on a single denture. We're supposed to check for that. So what I want you to do now, okay, is what we're trying to find now is these working and balancing positions. And so that's what the thought process was, is as the patient is chewing, one side goes into working, one side goes into balancing, they contact and help stabilize the denture. This doesn't, in my humble opinion, my dear colleagues, now here I go controversial, this doesn't work, because now you're trying to make sure that everything's touching at the same time in someone's mouth when they have food now between the teeth, yet the cusps are supposed to all touch and balance at the same time and work and contact. This doesn't work. So we spend all this time on an articulator trying to make this function, yet this isn't how it functions in someone's mouth, okay? What we need to do is take the articulator and do this. We need to facilitate a chew cycle. And then I'm watching to see how the cusps function within that chew cycle. So now I'm taking an articulator and I'm manipulating it differently than what I was taught, but I'm manipulating it more to what is akin in the patient. So now I'm checking for that, whether this is, again, a complete upper and lower or a single upper to natural dentition. This is what it looks like on a close-up of me now manipulating it in that chew cycle. And I'm watching for the hidden slide. So you can see the hidden slide develop here. And then depending on the chew cycle, I won't have the hidden slide. So if I need to grind the guiding planes. Now, whether the guiding planes are on the top or the bottom, I need to grind that to allow and facilitate that helicopter pad to land in. So I wanted to spend some time on a PowerPoint here just to quickly go through some things. So when I start whacking teeth together here, you understand why I'm doing it. So again, here's my key point of today is we don't chew in centric. So we all kind of say, Mark, my bite's right. Mark, my bite's right. Mark, my bite's right. My bite's right. My bite's, oh, the bite's right. Yeah, you don't chew in centric. Yeah, it's patient can find centric eventually, yeah. But did they hit and slide into it, or did they find it? Did they come into the helicopter pad? But you don't chew there. You chew with a chew cycle. So we want to, again, further our relationship with you. So thanks for tuning in, and ergo that patient who puts their trust in you, and you can be that superhero to your patient. These are the reps. So Jim's going to bring this up later as well. I wanted to include this now so that if you're watching this on the recorded version, then you can find out who you need to phone. And you can be a superhero to your patient. So now I'm going to switch over and we're going to go back to the camera. And now I'm going to show you some teeth. So what I and do and let me get dirty. Whoops, let's find that again. There we go. One moment for it loading. Okay. So I wanted to take some time to quickly show you some of that, the technical aspects of things before we run into now why I do what I do. So I approach this quite a bit differently now than I did when I started, and that's my journey, and so be it. My dad said it right. You know what, Mark? Yeah, you want to be doing it for 30 years, but you don't want to do it 30 years out of date. And that's a profound statement. And I want to say this because we've been locking in our occlusion. I have no time for 10, 20, 30 degree teeth. They're locked in. They don't have freedom in centric. They're designed from the 1940s and 50s, and it's not the 40s and 50s anymore. And it's time to move on. And it's time to roll with teeth and use teeth that function and are following new theories and trends, as is everything that we have in our society and in our lives that has developed and moved forward. Well, so are we. So for those of you that are roughly my age, you'll remember the Atari system and the little ping pong game. And we thought that was so awesome back when. And now look at the technology of video games and Halo and these types of gamings that are out there. Yet it all started from that original Atari and the little ping pong thing that we were stuck onto the TV with and sat there for hours. This is my point, is that we move forward with theory and technology, and now it's time to move forward with that with teeth as well, and understanding. So the first thing is that on lower natural dentition, you get a mixed bag of everything. And so what I'm trying to find first off is sort of where is the deepest point, and is there a sulcus, or not sulcus, a fossa on any of these teeth that are left. Sometimes they're great and you can see them, and sometimes they're not so great and things are really flat. So I'm trying to find, you know, where the crevices are and where the fossa is, because I want to take that upper tooth and I want to take preferably the lingual cusp of the tooth, of its antagonist, and place it into the fossa, the best fossa that I have. And then it's got to function within the guiding planes of the tooth. Now, typically what we've done in the past when we've built teeth is you have the lower, and then I take the upper tooth and I take articulating paper and some type of a grinding instrument or a big fat burr, and I take it and I just hack the thing till it's solid. And then this becomes basically it's almost like the solid piece. And then I try to do a little bit of working and balancing on it. And then I say, pat myself on the back and say that it was good. I want to impress with you here that when you leave no space here and things are really tight, like we've done, and things are tight here, where does the food go when you come up and start to chew it? And this is a tight surface. Where does the food go? Well, the food gets pushed off. It doesn't stay here and get crushed. The food actually needs to stay partially on the tooth to continue to get crushed. So the one thing that you picked up from the chew cycles is it's a mortar and pestle. So the fossa's here, and then you've got the big hammer cusp that's coming in, and it comes down, and this is holding the food, and it gets crushed and minced while it's going through a chew cycle. So when we go flat, what happens is the food keeps getting pushed off, and that's not effective. Now you're saying, yeah, but Mark, okay, what do you do when it's flat? When it's flat, okay. So that's again why we're going to come back to this. So what do you do when it's flat? Okay, well, so now we're identifying that. I'm trying to find the best part to put the tooth. And then what I'm going to do is I'm going to custom grind and customize that tooth into this lower natural dentition, but not just go in quickly and hack it into position and get it really tight. I want to leave some working room in here so the food still has, it doesn't get pushed off the tooth, that there's gapping in here, and that when we facilitate the chew cycle, that it doesn't hit and slide into position. So as I back this off, I'm going to just take a moment to show you. So on my articulator here that I have, I manipulate it and I do. So if you look at the pin up here, so I'm learned and taken my hands now to facilitate a chew cycle. So if I throw some models in here and back up the articulator even more to show you, it's the same thing. I am just taking this. So instead of that standard this, because this is not how this thing works in the mouth. Now, out of all those videos that I just showed you and that you saw, this isn't how it works. So I go through this chew cycle and I'm learning to manipulate the articulator, and I can do that on any type of articulator. Look, here's a hinge articulator. I'm just taking it and I am now facilitating the chew cycle. So I'm not just going the standard, what school taught me, so to speak, or what the textbook says I should do this way. I'm taking it and I'm holding the articulator and I'm going to facilitate the chew cycle. And I'm going in what I believe to be the patient's cycle, whether it's more horizontal, whether it's more ovoid. I'm trying to facilitate that, and you can do it on any articulator. I'm just manipulating it in a different way, okay? So I'm going to switch models, and bear with me. I'm going to pop back and show you this. So now you can see. So we have dentition. So again, different, okay? This is really worn off. And so it kind of is what it is, okay? You've got this mixed bag in here all over. So the question lies with, again, how do you set to this? So we're going to set within the freedom concept in mind. So bear with me now. I'm going to put myself to work, and I'm going to show you what I do. So we're going to do this in real time. What I did not want to do is preset everything, because then where's the fun in that, where you get to see the finished product? You actually want to see me get to work today. So forgive me while there we go, find the zoom button. So we're just going to get some wax in play here, and then we'll get some teeth, and then we'll show you what I do. Following the freedom principles. So I manipulated things a little bit on the registration so that I give myself lots and lots of room for a demo purpose, okay? So now you can say, okay, how am I going to set teeth? So we're going to just start with some teeth, and let's see. Okay. So I'm going to use lingo form on this one. Okay, these are acrylic glass. So there's glass particles embedded within the acrylic. So the reason why I like this is I can touch it, grind it, and I don't have to polish it. I don't have to polish it because the glass in there self-polishes. I don't have to polish it because, again, because of the glass, it doesn't leave it abraded and wear down even quicker. It's going to self-polish, and it's going to hold and maintain its wear cycle for 5 to 7 years. That's why I like this product. These are the Freedom teeth, so they have Freedom and Centric built in and Freedom Principles built in, which is what I've reviewed with you now of a little bit of a smattering of what all that is. So I'm going to take the first premolar. Okay. All right. So I'm just going to go in on its own. Okay. Somewhat there. Okay. So what we typically do now is we'll take articulating paper. So allow me to fetch some articulating paper. So we use any type of standard varying thickness of articulating paper in our office. And what we do, and what I mean by that is what we do, we as in collectively, when we build an upper denture, is we take the articulating paper of whatever we use in our offices, and then I start tapping it in, and then I start grinding to get this tooth nestled in tight to this tooth. And then we typically lock it in like I've showed you, where it's fairly tight. And then I'm going to do a couple quick movements on the articulator to facilitate working and balancing and say, good, I've done my job. So I'll say, for argument's sake, that this tooth is in the correct position here. So say you set your upper anterior teeth. I'm going to leave the uppers off just so that we can concentrate and see this more clearly. So what I do then is I will take that tooth and yeah, we have a couple of options. I can use articulating paper, okay? And I can tap in centric and see where the center contact is, with the understanding of when the teeth come in together and they bite into the paper, that this does bend a little bit and it can give me some wrong readings as it bends microscopically between the teeth. So that can happen. So I have to take articulating paper with a grain of salt, okay? The other things that I've done and have tried is I'll actually color the tooth. So I take this is a Stapler pen, or you can use a Sharpie, okay? So long as it's non-permanent. This one's made in Germany. So you go in and I can color the tooth. So I've done this as well. And then I actually come in and I can tap it. And then what it's going to do is it's going to start to mark the bottom, just like articulating paper does. But what it's also going to do carefully is it's actually going to mark away too where the center contact positions are, so I actually can see on the tooth itself. So let me get that better focused for you. So it actually will let me see on the tooth itself where the center contact positions are, because the ink gets marked away. The nice thing about this method of not using articulating paper is then there's no bend. I'm not worried about the paper bending between the teeth and giving me a false reading and crinkling and maybe giving me too much of a marking where it wasn't necessary because of the defects in the paper and how it's being crunched between the two teeth. So I actually like using this. It's a little bit, you have to get used to it, okay, in terms of it. But I like doing it because then it lets me see, okay? And so now I'm going to grab a burr. Now, typically speaking, you can use anything that's very fine, okay? So something just very fine. As I'm going through my burr list here, hang on, you can hear all the ones falling out that I'm not looking for. And then you can come in with a high speed. And then what I'm going to do is I'm going to start to touch and grind the cusp. So what that does is that is going to start to flatten this cusp down. And it's going to start to flatten it into the fossa of the lower. So then I'm going to recolor. And then I'm going to come in and I'm going to touch and centric. So I'm going to take the pin out of the way so you can see this. So I'm going to come in and I'm going to touch and centric. Okay. And then I'm going to come back and I'm going to look. And I'm going to see what's happening here. So let me center myself. So the trick about working with these document cameras is we have to get the right, there we go. Okay. So now I can see that it's hitting a little bit here on the edges, not so much in the center. So I appreciate that doesn't translate so well sometimes into a field of vision here with the camera. So let me bring this in. There we go. So we're starting to get a little bit of marking in here, and you can just see that it's hitting in here just a little bit for me. So I'm going to take the burr. There we go. Again, come in with the color. So if you want to use articulating paper, that's not a problem. I've switched and gone to this type of marking system, as I'll call it, because I found that the paper was just bending and not giving me accurate results. And so now I can kind of see, again, it's hitting right there. So what this does is just going to eliminate the paper bending and giving me a wrong reading that I just cut in. Because what I'm doing is I'm spending the care and the time here to not just hammer this thing in knuckle tight. That's the purpose of this, is I want to leave gapping on the contacts. I want to leave gapping but on the teeth, between the teeth. Let me see if we can. I want to leave some gapping in there, okay? So that the food has somewhere to stay, so that when this is functioning, that the food can stay down here because it's the lower bringing it up to get crushed by the upper teeth. So that was thinking number one by what I'm showing you. The second thing now is again, typically we would open the articulator and I would do this to facilitate the working and balancing contacts. Again, what I'm establishing with you is we don't do that in real life. I need to start to go through the chew cycle. And then I'm looking to see how the tooth functions within that chew cycle by manipulating the articulator. And then what that's going to do as well is take the teeth and it'll mark for me. It'll mark for me where the tooth is hitting, or I can see it on the lower model where it's hitting right there. And then that allows me to customize the tooth in. Okay. Okay, I'm going to heat up and we're going to switch over to the molar here. Jim, I have a question.
Yes, sir.
Hi. How's it going?
How are you? Things
Good.
are going well.
I'm working hard.
You're making that wax hot.
Yeah. Do we have any questions that are popping up that I can answer as we go here?
Sure. So, what tests do you use to determine if a denture needs relining?
Okay.
Or is there a test, or how do you check to see if it's time for a reline, rebase, reline?
Right. Okay. So, hang on while I go into my little samples here. I don't have a complete denture right here, but let me do this. Okay. So clinically, what we do is this is imagine this is a complete upper denture. Okay. I take my fingers and I go in the mouth and I touch on the premolar molar area, and then I rock the plate and then I do this to it. So what it's going to look like in the mouth is I'm trying to rock it this way and then I'm trying to rock it this way. So I'm touching my fingers here and I'm pushing and then I'm rotating. So what I'm trying to do is I'm trying to see how this denture fits on the gum structure. So I'm trying to take it and I'm trying to do this and I'm trying to do this. So imagine it's like your foot within a loose shoe. You can take your foot and you can move it around within that shoe. If I can do that, so if I can take this thing and it's a discernible rock and it's a discernible motion, okay, probably needs to reline. If I push hard enough, I'm going to displace the tissue. So I expect to see a little bit of this. So I would take it, and if it's fairly tight and I do this, and it's got very little give, then I'm going to say, whoa, wait a minute, Mark, probably doesn't need the reline. The second thing I'm going to do is I'm going to ask, and I'm going to give the patient a sip of water to drink. And then they're going to take the sip of water. They're going to go through the motions of swallowing. The teeth are going to come in together with centric contact to brace so that the muscles can swallow the water. And then they're going to open. And I'm going to take my fingers and I'm going to touch on the anterior teeth and I'm going to try to dislodge the denture. And if the denture can hold in without coming out right away, then it doesn't need to be relined. Because what that does is if the center contact is right and they didn't hit into slide into position and there's not a lot of wiggle room, then it fits. Then the problem is being caused then by the occlusion when it's functioning. So it's either loose because it's physically loose on the tissue, or it's loose because of the function while it's functioning in a chew cycle. So what I determined, two-step approach. One, check to see how much rotation there is on the ridge. Second, drink of water, swallow, and then I try to push the plate. Okay, so whether it upper or lower. And if it holds in, then that tells me the centric was fine and there isn't a lot of breakage of the seal, which tells me then if there's issues going on, then it's not a fit issue, it's a function issue. Okay, great question. Jim, next one.
Yes. All right. So,
Awesome.
Do you do all of this without a facepull and eccentric records, or is this an average wiggle?
Without a facepull?
Yeah. Do you do this using a facepull, or do you use an average method?
Okay. So that opens up a whole other PowerPoint and a whole other group of slides, everyone. But let me just answer it this way. This is a Protar articulator, and it's designed to fit with a face bow, but they call it an ear bow. So I want to point out a couple things on this articulator. You can see mine is well used. I love this thing. It is probably the best investment of my money to help patient care that I've ever done. So when you open and close the articulator, this is the hinge access point. So the hinge access point is where the condyle first starts to rotate, and then what's going to happen is when they open, it translates down. So that's the condylar angle. So there it starts to translate. but at the very first moment of movement was where I was trying to get my mouth around, is this is the hinge access point. On the face bow itself, what happens is it's called an ear bow, and the way that the piece goes into the ear, it's recessed a little bit, because where this hinge access point is and then where your ear is back here a little bit. So Cavo has adjusted and made it so that where the face bow goes in is slightly off from where the hinge access point is. Now, I don't have my face bow right next to me here, with my apologies, as I'm pulling into drawers. That's in the treatment room. So I can't show you the earpiece, with my apologies, but I do have an average value mounting jig. So what can happen with face bows is, because the face bow is referencing the ear, and the little, depending on the face bow itself, the different types of manufacturers, they all go into the ear, but it's not referenced to where the hinge access point is of the temporomandibular joint. Okay, so the hinge access point is ahead. So what happens on face bows is there's an inherent error where this model can be canted a little bit differently because of the way the arcs and angles work in the jaw and in the skull. And typically you'll find that those models get down like this. So people say that often. Well, Mark, my upper model is dangling down a little bit with a face bow. So Cavo's tried to overcome that by modifying where the earpiece is in relation to the hinge access point. But one of the biggest things that I've learned from using a Cavo face bow is, when that thing goes on the patient, ta-da, when that goes on the patient, that face bow should be on extremely tight. So what the ear bow is the ear bow has the piece that goes into the skull is crooked a little bit, and it goes in, and then it's supposed to slide forward, so it comes right behind the hinge access point of your condyle. That's the deal. It's not a straight piece. Some face bows are just a straight ball that just goes in. But how do you know how it goes and how far it goes in the ear canal? The Cavo one is crooked like this, and it comes in, and it's supposed to go all the way in and forward. So when you put the face bow on, I'm actually supposed to push it on, and then I push it forward to engage right behind the ear. And this thing should hurt. And now I got to be careful when I say that. I warn the patient, this may cause you some discomfort. This thing should fit snug. I should be able to do all this movement without the face bow coming off. And when you're done, there should be a little red welt here that it was on, again, right in here tight. What that does is that helps eliminate that canting of the model coming down. Now, you also can use this. So this is it's for a lower, so this is an average value mounting jig. And then what this does is this also sits within the articulator, and this references, now let me find an edentulous lower model in a hurry. Okay, so we have a model. What this does is this is going to reference, so 18 millimeters, which is our standard reference height. This black portion is going to go into the sulcus, the front sulcus. So let me hold it this way. So it goes into the front sulcus, and then the back will reference 2/3 up the retromolar pad. So that's this. So let me tighten it so that it holds. So that's this piece here. So what this does is, when you flip the model upside down to articulate it, what's happening is we're using anatomical landmarks to orientate and reference this model. So I'm going by the sulcus, and then I'm going 2/3 up the retromolar pad. And then what that does is that orientates and cants. And then this fits within the articulator. So let me take this stuff off to show you. So this goes on the top. So let me flip around now, so bear with me. I have to take everything and now reflip. And the model comes on the lower, and then it'll close. This really doesn't do it justice on a video camera, everybody. So it goes on here at the retromolar pad, the articulator closes, as I need way more hands to do this with a video versus live. And then what this does is this orientates the model, okay? So it's gonna orientate it. So let me just flip field of vision here for you. So thank you for your patience. This is something far easier to do in person. So by having this all kind of jigged up and geared up here, then what this does is this is going to orientate the model like this using retromolar pad sulcus. And what that does is it's popping this model inside the Bonwell triangle of this articulator. So the Bonwell triangle on this articulator is the hinge access points here of where the condyle is. So that's the condyle right there. So it's taking that and then the reference to the incisal edge, and that forms a triangle called the Bonwell triangle. And then that's setting this model within that triangle using this jig to anatomically mark it. So we do that with a face bow on the upper, or we can do this on the lower. There is an upper jig as well that uses, again, the sulcus, the papilla, and then the tuber or the hamular notches on the upper to orientate it as well. So you have to understand that there is a degree of error with a face bow. It's usually anywhere from 7 to 9 degrees of error, and 7 to 9 degrees is a lot of error. And that's why you hear the comment of, well, Mark, how come my upper model is really this way in the articulator? Well, that's that error where did you get that face bow really snug up into the patient to counteract these points where the bow in the ear is behind the condyle, and then that's what's causing the error in the degrees of angulation. So I like using these. I like using these jigs because they're using anatomical landmarks to orientate within the Bonwell triangle. Those anatomical landmarks are referenced and they're accurate. The other thing is that for the face bow to work, it has to be on really snug. And so, yes, I'm sitting there and I'm gonna potentially cause a little bit of pain for a patient to put this thing on and have it really snug and engaged properly. The thing with the face bow and the Cavo face bow, because the earpieces have that little crook on them, you put the bow on and then you slide it forward. So it's going in the ear canal and forward. And then that is, you can actually see the bow slide forward in the patient. So it's like taking my finger and then I can stick it in my ear, but I can also go forward into my ear. And then that starts to hurt a little bit. But that's the idea, is I want that bow in and forward as far as you can. So you actually put the bow on and then you can tug that thing forward quite a bit. And that's going to eliminate the angles and that dropping. But this works extremely well. And then we don't have to put the patient through it. So that was a long-winded response. Sorry about that, but now we got really technical on that. I like using the average value mounting jig. I have the first and second generation Digmas in my office, which is the digital analyzer from Cavo. So I call it you can call it a digital face bow. Again, you're hooking all this stuff up to a patient, and yes, it gives you accurate information. It takes the degree of error down to 1 to 2 degrees, so it's quite accurate. It's just, again, another contraption on a patient. So I've been trying to get my hands off of people now at this stage of my career. I like these things because they are accurate, but now I'm trying to work within that envelope to understand that the way you orientate a model within an articulator creates that arc and angle, and then that arc and angle plays out here. So it may look good here, but then it doesn't play out well here and in the mouth, because this is a discernible distance between where this is, where my teeth are, and now the hinge axis point of my mandible and my condyle, which is here. This is a distance, this is an angle, and this functions at an angle and an arc. So everything goes back to math. I know, math. So everything goes back to math, okay? Arcs and angles. So that was the disconnect, where it looked really good here, and then I stuck it in the mouth, and it was like, well, what the heck? Well, yeah, well, now I realize the Bonneville triangle is really important. And so, Jim, that was my long-winded response. How did I do? That was heavy.
Excellent.
That's a
Excellent.
lot
We'll
of
have to make
technical
another
guy.
webinar just on that.
Well, and then we need to get co-sponsored by Cavo. So that's the other thing. Because you guys, I have a ton of information from them as well that plays well with the arcs and angles and slides and stuff. So pardon me. Thank you for your patience on that. Jim, is there another question, or I'll just keep motoring on here?
Go ahead and finish up what you have. We have several questions left, so
I love questions.
I want to make sure you get through your what you're doing, showing.
Okay, let me switch models. Well, I just wanted to show the molar here, because again, this is what we face, where we've got cusps now on the top. The bottom is really flat and got an angle to it. So how do I orientate this tooth? Because typically now what we do is, when the lower looks like this, then we're going to grind the upper to match it, and everything's got this cant on it as compared to the horizontal. There goes my horizontal, as compared to the horizontal. So we got to be careful, okay? Because now what happens is as they go through the arcs and angles and they close, what happens is the directional force is going this way, and I want it to go up and into the ridge, because remember, there's a ridge here. And if you cant the tooth, then this sucker is going to point out, and that causes a teeter, and then that's what's causing the upper denture to break, because now here's the palate. All right. So, all right. So bear with me. Clean sheet of paper. All right. So let me use articulating paper on this one. Okay. So I'm going to take the tooth, and then I'm going to start to tap it into position. So you can see that point is referenced there. So let's work with that. So I'm going to take the tooth, and I'm going to start to slowly grind it. So I got to take the cusps down. So this is a diamond burr. And again, I'm going to come in, and I'm going to use the paper. And again, you can see I'm flattening those cusps out. So how I'm going to orientate this on this tooth, let me grab my little pointer. Okay, I'm going to want to kind of center it onto the center of the tooth. But what I'm going to try to do is this, and I'm going to draw it, is, okay, here's the lower, and it's flat. Okay. Now the upper has that discernible cusp on it, okay? And what I'm going to try to do, the goal of this is I'm going to take this cusp, and I'm going to flatten that cusp down. But what I'm not going to do, okay, so that'll be more flatter against the surface in principle. But what I don't want to do is take the tooth, because now that lower is at an angle. I don't want to angle the upper. I want to keep the upper this way. Oh, let me redraw that. That's terrible. This is why I'm not an artist. Okay. So if that's this way, I don't want the upper tooth also angling this way, so that directional force is this way. I want to take it this way, but I'm going to grind the tooth so that it kind of touches, but then comes out. But the tooth is more upright. So what I'm doing is I'm taking the cusp and I'm gonna slowly make it touch this way, yes, but keep the tooth pointed this way, not tilt it down and just mimic that to mimic that. I'm gonna grind it in, but keep it upright. Does that make sense? Jim, this is where you come on and go, yes, Mark, that makes sense.
It does to me.
Okay.
Makes perfect sense.
Nice. Thanks, Jim. So we're going to do that because that was the one thing is I would always take this tooth and then I would tip it to match the lower and everything was angled. Well, and I would say to myself, yeah, but it has to be. And no, it doesn't. That's wrong. And then I'm building in that torque. So what I'm doing is I'm taking that cusp down, but I'm taking the cusp down in that angle, in that manner. So you can see how it's slowly starting to come together, but I'm not tipping the tooth. The tooth is going to stay, let me use a knife. The tooth will stay more upright. I'm not tipping it. So please, you guys don't, because then what that does is when they bite together, all the force is coming out here, and then it's just going to sit here and teeter on the palate. It's going to cause this flex, and that's what causes the breakage. Or it flexes, and that's what's causing it to come loose. This was a big aha moment for me when I started to figure this out, because I got tired of banging my head on the wall, going, why isn't this working? So as I bring that tooth into contact on this form, using articulating paper for this time, so that's allowing me to bring this into contact. So my goal again is to have the lower look like this. The upper is going to come in and bury itself in, yet then I'm going to keep the overlap, and it's going to look something like that. Hey, I drew that actually not bad. So the idea is I want this buccal cusp overlapping the bottom, because this kind of helps keep the food from squishing off. It's a shearing cusp. So this is there to kind of help keep the food on the food table. The tooth is still orientated in the right way, even though this one's going this way. This one's going up into the ridge and into the stability here. And then I'm keeping the overlap so to keep the food in. So it's not just get her in tight, And then I'm working within that chew cycle of the patient and then watching this. So believe it or not, I'm not so much concerned now of the old, oh, do I have working and balancing contacts? No, I'm actually not really concerned about working and balancing contacts and if they exist. Did I just say that out loud? You don't need working and balancing contacts, because this doesn't chew with working and balancing contacts. You don't chew with working and balancing contacts. You chew in a chew cycle. So if for sure of those that know me well, I am controversial when I start to talk, because now I'm setting up teeth without working and balancing contacts, because you don't need them. This has to function within the chew cycle. So the idea now is that I'm taking it and I'm tapping. Let me try that again. Tapping, and I am bringing this tooth into its alignment. So I'm grinding this at the angle of what the lower is, yet maintaining the integrity of the tooth this way. Okay, and then it'll function within the chew cycle parameter of this. And that's how you set it up within the Freedom System so that this thing functions. So I am not going to sit here and tediously try to find working and balancing contacts. I'm concerned about my wiggle room. I'm concerned about a helicopter pad to land in, and I'm concerned that this can function both ways without interference. And then I am checking to make sure that I am not hitting on the guiding planes where this thing is going to cause it to rock. Okay. Okay, Jim, do we have another question?
We have several, so let's start with this one. You're familiar with the Stratos articulator?
Yes.
So for immediate side shift, the question is, immediate side shift on a Stratos, what value should they set it at?
So you have a Stratus, I think it's the 300. So set it with, so that it has a millimeter. So the Cavo one, that dial is right here. That's this black one, and I can set it 0.5, 1, and 1.5. Typically, I'm dialed in to either 1 or 1.5 at all times. So I would say your Stratus, same thing. Please have it at least a millimeter of wiggle, if not more. In this case, more can never hurt a patient because again, they've lost they've lost the proprioception, nerves and nervous system tactileness. So they've lost that. So if you give someone an extra 0.5 millimeters to land in, that's fine. So I would give them at least that millimeter of wiggle room or at least 1.5. Okay.
So this might be a bigger answer than we have time, but how do you determine vertical dimension so patients have optimal function?
I'm giggling because somebody wants me to get really controversial. So I'll give you the textbook answer. So you should have 1 to 3 millimeters of freeway space. You should have 1 to 3 millimeters of freeway space. Why? Because that's what the textbook tells me I should have. 1 to 3 millimeters of freeway space. And so I should have that when you take the measurements here on the dots, or I should have that. So that would be a standard vertical dimension. Okay, so let me get controversial in 1 minute or less. This is about a person. How do I know that 1 to 3 millimeters of interarch distance or freeway space is adequate for me? How do I know that? How do I know that I should aim and Mrs. Smith can tolerate 1 to 3 millimeters of freeway space? Because that's ideal because the textbook told me so. So she comes into my office. Number one, I look at the person. So part of this now is on other PowerPoints and other lectures you hear me talk about. I look at their hand and I'm looking at their skin. Do they have arthritis? Can I see through their skin? Can I see their veins? Do they have arthritis? Their fingers critching? Do I see a lot of bruising? That's telling me about the person. That's telling me about where they're at in their point of life and what their health is doing. If the skin is thinning here, it's thinning in here. If they're bruising here, they have a high risk of bruising here. If they have arthritis here, they're going to have arthritis probably here. So now is 1 to 3 millimeters okay? So say she walks into my office and she's at 5 millimeters of freeway space in her mouth, but she's not symptomatic. So what does that mean? I do a clinical examination and I see, is she exhibiting symptoms? Why is she in my office? Why is she here? Well, my dentures are loose, they're worn down. Okay, they're worn down. Are you symptomatic? So do you have ringing in your ears, pain behind your eyes? Do you have vertigo? Do you have a ringing in and in your ears? Are you symptomatic at that height? Because if I open her up and I take her from 5 millimeters to 3, I'm lengthening her face 2 millimeters because remember she's over closed, so I'm lengthening her face. but then I'm repositioning her condyle. So I'm repositioning the condyle because now I'm opening it, so the condyle is going to go back into the fossa more. Is that okay? So the question lies with you as a practitioner now. Can she tolerate that change? So if she's very frail and has thin skin and is bruising and is coming in on the walker and is a little thing that you can blow over with a gust of wind, and I start talking to her and I say, are you wearing a watch? Is it tight? Do you like the compression of a watch? Do you wear your wedding rings? Do you like the jewelry on you? Do you like tight clothing or loose fit clothing? That's going to tell me whether or not I should be the ideal vertical dimension for that person. Example, I had a fella come in, he brought in a bag full of teeth, and he was here on a consult, and he's like, none of you guys know how to build teeth. I'm like, well, actually, we know how to build teeth. But why are all these failing for you? I go through that. I look at his hand, his skin. I start trying to figure out, what am I trying to figure out? How sensitive is this guy? So now he can feel a crumb in his bed when he goes to bed at night. So I asked him this. I said, are you super sensitive? Because I'm getting a feeling you are. Are you this type of guy that likes loose clothing and doesn't like things touching him? And, you know, I'll take a hug from my wife, but really don't hug me hard. And I go to bed at night and I have to have everything clean. And this guy vacuums his bed out every night. He's got one of those handheld vacuums and he sucks up because he can feel a crumb in his bed. So what does that tell me? Super sensitive guy. So do you think he's going to tolerate if I open his vertical dimension? Everyone, all those bags of teeth, they were at the right vertical, 1 to 3 millimeters. Where did the guy need to be at? He needed to be at 5 or 6 millimeters, not textbook. So this is about getting out of my way, getting out of your way. This is about looking at who you're building it for. This is about building the denture for the patient, not the other way around. Thank you, Dr. Carlson, for that. This is about understanding who you're building it for and denture integration into the body. That's where I'm honing my skills now at this part of my career. Understanding who I'm building it for. And then I can stand in front of a group of my peers and say, why did I build it this way? Why did I give her this much freeway space or this little freeway space? Why did I make these key critical decisions about her dental health? And you can see everything will be listed out and I have a rationale for why I did it. Is that not what we're tasked to do and make key critical decisions for a patient, regardless of whether you're in the lab or whether you're wet fingered and you're doing it? That would be my answer to that question, Jim, is you have to look at the whole person and then you make the clinical decision of if they can handle a textbook. If they can, then you do it. Yes, because that would be ideal. But again, if they're older and more frail, here's my thing. Do senior citizens handle change well? Do they, in your opinion? Do they handle change well? Yeah, what do we do all the time? They come in this office, they come into the treatment room over there, and what? We're changing things. Now, granted, they understand it's going to change, but we change too much. We forgot who we're building it for. That's my answer to that question, Jim. I went over a minute.
That's okay.
Do you think I answered it?
Yes.
Unless we can patch them through, because that's a tough one, but it is a multifaceted, long-winded answer with many pieces of the pie that influence that decision.
Well, we'll show them your email address soon. So, so the another question was, do you use the average settings or do you customize your articulator for each patient with individual records?
Ooh, you guys are on fire today. Okay, so the answer is yes and no. The answer is now depending on the patient and what I think they can tolerate and not tolerate and what I need to help mold myself to them. If I think that I can get away with average value, and if I can get away with what I think a millimeter of freeway space, and I think they have an ovoid chewing cycle, then that's where I'm going to go with my numbers, as I'll call it. But if I think that I need more information because I'm not 100% sure in my estimations, then I can use a FACEBO or a Digma. Or I'm going to go to 1.5 on the CAVO here. And I'm going to give them a little more freedom based on what I'm looking at. I'll have them bring food in and I'm going to watch them chew. And I'm going to ask them to bring food in and watch the cycle. There's some things that I can do to help me gain that information. So to answer the question is it varies from patient to patient, and the complexities of that patient and what drew them into the office in the first place, of what the problems that they're experiencing. So then that'll affect how I amp up and how I act to that patient. If that adequately answers your question, I hope so, my dear colleague. It depends. But that's why I have a lot of things in my office here, and things meaning tools in my office. I have a FACEBO, I have average value mounting jigs, I have a CAVO, I have a Digma. I have all these things at my disposal. I have a TENS unit because I get to play with a TENS unit in Alberta legally. I have all these things at my disposal based on what I think I need to do, based on the patient and what I assess them to be, and then why are they here and what are we trying to, what's our end goal? You got to start with your end goal in mind. Well, the end goal is they want to go to buffet world and eat and not just have mashed potatoes and gravy. So again, I have to look at the whole individual and then I act accordingly. Typically speaking, this works really well, these average value mounting jigs with lingualized occlusion set in an articulator where I'm trying to mimic their chew cycle, and I'm usually dialing 1 to 1.5 millimeters within that helicopter pad. And it's usually 1.5 for most people, because again, as we get older, our neuromuscular system gets less sharp. We're not functioning as accurately and as pinpointingly as we are before, especially if you have a patient that's starting to show some shaking or tremors, then that's hard, because then they're not going to be able to land centric as accurately. So now I'm really giving them 1.5 or more. And all it is on CAVO, on VITA teeth, is just grinding the guiding planes. And then I love it because that frees up and makes a bigger landing pad for me. I don't have to polish it after because of the acrylic glass. So it's way easier for me. Jim, next question. And we're almost running out of time. This should have been a day. It could have been a day.
So Dan has a question on the, can you use the average value mounting jig? Yeah,
yes.
definitely.
Hey, Denture Dan!
Can you use the average value mounting jig on both the upper and lower and no bite registration at all? So just the two jigs?
No, not with the CAVO. You can with the Staub cranial technique, which is a whole other different technique, Dan, that you and I think I've chatted about, but no, you have to use one or the other. Pardon me. So you have to mount either the upper or the lower, and in reference to the CAVO now, I'm referencing to the Protar system. I have to use one or the other, and then I do need a bite registration to do it, yes. The Staub cranial technique, I do not, but that's a whole other technique. But for CAVO, average value mounting jig, upper or lower, not both, and yes, you need a bite registration.
What is preferable?
I like the upper because I'm referencing, I have got it so I can reference the incisive papilla and then the hamular notches, and I like that best, and not the sulcus. I'm using the papilla and the hamular notches, which are pretty stable unless they've been surgically altered. So that's my favorite.
All right, and this is kind of reaffirming. This is kind of reaffirming what you said, but so against the lower natural dentition, you focus the lingual cusps of the upper in the fossa of the lower.
Yes.
But keeping the neck in.
Yeah, don't tip the tooth. If the lower's tipped, you try to just grind it in, but keep it straight. Grind down here and make it curvy or whatnot, but keep the tooth straight. Directional forces go up. You want to keep the overlap so that, again, the shearing cusps are intact. Yes.
And then would you prefer lingualized occlusion setup?
Yes, always. Or a variation of it. So I'm going to variation lingualized occlusion to this. Yeah, it's a variation of it. I am 100% lingualized occlusion concept minded. Yes, because it works. And that cuts my adjustment rate down. It cuts the common problems that we see with dentures down, and I'm less stressed, and I have less burnout.
And then this is a comment from Ahmad that he says he stopped worrying about working and balancing and haven't had a problem since.
You got out of your way. Good for you.
There you go, Mark. Some affirmation on what you teach.
Good for you. You got out of your way. And that's hard because it was so grilled into us that you have to have working and balancing. And I don't. I've built things without working and balancing, locked like this with 6 millimeters of overbite. And now I'm not scared by that anymore because you got to let go. Gosh, I sound like Frozen. You got to let go. And kudos to you. Woot woot. You get a woot woot from me. Because you don't always have to have working and balancing. It's not a must anymore. And that's why, thank you for getting with the modern technology and theories and leave the 50s behind. So it's a task. It's hard to do, but thank you for doing it. And thank you for that affirmation. That's fantastic.
So we have a few more questions, but we're kind of out of time. So I want to start wrapping this up.
Okay.
I'm going to go to if you're good, I'm going to go to my presentation.
Okay.
And we will go over the last few things.
Jim is going to seize control.
Just barely, though.
Okay. I'll shut myself out of this camera then.
So those of you who have asked about CE, that'll come later. And then, so we'll use your registration information to provide you that CE. The workshop itself has been recorded. I sent out to everyone the link to our VITA YouTube channel. You give us a couple days to post it. We kind of edited it a little bit, get rid of me, picking my nose, things like that. And then that'll be posted in a couple days. And then we have many more webinars as well. So I hope that you can join us again. This is if you want to contact the help desk here at VITA North America. If you have any follow-up questions, we can help you out. And then this is what Mark showed earlier. This is just a list of the representatives in Canada and in the United States. We have the other programs, a whole calendar full of webinars. This is not everything. This is just the first part of the year. Mark is actually going to be doing a presentation, a 3-part series workshop on step-by-step on setting up later this year. Mm-hmm. So hopefully you can join us. Mark, that'll be exciting. It'll be different, new, and we'll see how that goes. And then, of course, if you need to get a hold of Mark, Mark graciously has provided us with his contact information, as you can see here. So please get a hold of Mark if you need some follow-up. He is a working denturist. So, if he can't get back to you quickly, give him some slack. He's got other things going on in his life as well in the real world for actually making a living, because we really don't pay him much to do this webinar. So I think we give you a free hot meal is about it. So let him get back to you, and he'll work it out with you on as far as answering your questions. So anything else, Mark, you want to share with the team?
We're here to support you. Thank you for investing in yourself, and thank you for taking time. So we veered a little bit here and there today, but you got the gist of how I approach a single denture and why. And then we kind of branched into some related topics as well. So if you have topics in mind, email Jim, and then we can discuss about doing a formal webinar on it. As restrictions are starting to also lighten a little bit for us, get a hold of Jim, send him an email and ask him about some hands-on courses and in-person stuff. We can organize it if there's enough people interested, or we can come to your office and if there's enough people, do it also for you privately. That's not off the table. We just have to see about logistics and such. But look, we're here to support you, and we're here to help amp up your superhero skills. And thank you for hearing me out. And again, we don't slap teeth together, and we're here to facilitate and to care for someone that places their trust in us. And that's a big deal. And that's been some of my journey in my career and my profession now to be able to achieve that and help someone eat more than mashed potatoes and gravy. And so thank you for letting me challenge you, and thank you for hearing me out. Again, we're here to support you, and we want to support you. I'm thankful to VITA North America for investing in this and in me and in us collectively. They understand, and they're here to support us. And I really appreciate that from them as well. So thank you, Jim and VITA North America, for all this. Jim does a lot of behind the scenes work to put on all of these webinars with myself and my other colleagues that do this. And so we're very thankful to him and the company for all of their hard work and putting all this on. It's a lot. They're running a heavy program, and it's a great deal of time for them. So thank you. And thanks to you for hearing me out, and I wish you well. And I hope to see you all soon in person. That would be awesome.
Well, thank you, Mark, for another exciting webinar. It was great. I learned a lot, again, as we always do, listening to your story and how you approach different concepts and so forth. And I want to thank everyone for joining us today. Please join us for another webinar in the future. Please visit us at our VITA North America website, and you'll get the information on when the next Mark Wagenseal webinar is going to be, or his remote hands-on workshop, where we will send you some models and you will follow Mark step by step throughout the process of setting up different various denture teeth concepts. And today, I want to thank you again, Mark. Awesome. And this will conclude today's VITA Learning webinar. Thank you.
Bye, everybody. Thanks. Ciao.